Thank you, Dr. Suhas sir, for inviting me for this prestigious program. And I'm also very happy that you asked me to speak on posterior polar cataract, which is a topic which is very close to my heart. I started doing this challenging situation, I think about 92 or 93, when there are not many techniques that were available while dealing with these cases. We did not know the various challenges. And I kept on evolving my technique. And since 95, 96, I've been following a particular method, particular technique, a strategy, which has given me very good results. And this is what I'm going to share with you in my presentation today. The main challenge in these situations is the fact that the posterior capsular rent can happen, and it can happen at all stages of cataract surgery. It may be pre-existing, like congenital posterior capsular dehiscence. It can happen during cortical cleaving hydrodissection. If it is performed by mistake, we don't do it. It can happen during nucleus cracking if it is not cracked properly. Vacuuming of the posterior capsular plaques, which again is not recommended. I have also have the mortification of seeing PCA develop while trying to bag the intraocular lens, and I have seen cases where in the recent past posterior capsular rent happening in PP's posterior polar cataracts during stromal hydration. I'm not sure whether that is related to flax which this patient had undergone. So they are seen in about 3 to 5 out of 1,000 cases that we do. 80% of them are bilateral. And these are very easy to pick up clinically. All these patients that are projected here had developed posterior capsular, had a pre-existing posterior capsular rent. You can see a spindle defect here. You can see the white dots, onion hole appearance, tri-radiate extension. So they are very easy to pick up. And in certain situations, when they come with an advanced nuclear sclerosis, in a brunescent cataract, where the underlying posterior polar component may be concealed, if you look at the fellow eye, if it happens to be aphakic or if it is pseudoaphakic or the PC, then you can easily assume that you are dealing with a posterior polar cataract. Recently, diagnostic imaging has been applied to posterior polar cataract, and for example, the anterior segment OCT. A lot of signs have been described. But however, if you have this technology, that is fine. But even if you don't have this technology, it's nothing to worry about, because all posterior polar cataracts, we are careful. Each posterior polar cataract is as important as the next case. The strategy that they follow is the same. So I have a strategy for soft cataract, for a different strategy for the hard cataract. This is what I'm going to show you today. This is an elderly man with a 3+ nuclear sclerosis. This is just to show you the technique of nuclear disassembly. And my main focus will be on the next video, which is a very happening video. A lot of complications happen and they were very well managed. Patient did well eventually. So here, the hydrophilic dissection was not done, so the nucleus cannot be rotated. So my game plan here is to chisel out a wedge-shaped portion of the nucleus from the nasal side. So the nucleus is elevated in the capsular bag, and the lateral separation that happens during the chopping, it is at a more anterior plane, so the forces are not communicated to the posterior capsule and the posterior polar component. And then I'm not rotating the nucleus. I'm just bending. I'm just tilting the phaco-tip to a superior side, facing superiorly, and then I create another chop. So I have created a big chunk which is freed off from the parent nucleus, and that is consumed. So this gives me a lot of space now in the central and inferior, the nasal capsular bag, for me to manage the subincisional lens matter. And for that, you can just lollipop the nucleus with the phaco-tip, bring it in a more accessible area, and consume it with appropriate parameters. Of course, a few manipulations happening in the anterior chamber at a more anterior level, and you need to protect the corneal endothelium with a dispersive OVD. So this patient goes off well. The next patient, actually, he was in his mid-70s. I had done his fellow eye almost a decade earlier. It was uneventful. After the rexis, I make a hydro-free dissection. Take a cyclodialysis spatula, pass the spatula the way you saw here, and then create a triangle. Like just in the first case I had shown, a triangle that is created from the temporal side, apex on the clear corneal incision, so that I get a tall vertical wall. And then I continue with the same maneuver. I just chop the nucleus. I'm going to get a large chunk of the nucleus. on the nasal side, separated from the main body of the nucleus, and subsequently did the same step that I'm going to follow. Now, cortical cleaving hydrodissection is something that should never be done, and I do a hydro-free dissection because it separates the adhesion between the capsule and the underlying lens matter, and thereby it creates a space. So subsequently, when you go for phacoemulsification, the fluid somehow tracks under the capsule, and at a subsequent stage where the nucleus is debulked, there's more space in the capsular bag, the nucleus sort of becomes smooth, but easily rotatable. So far so good. And now at the end of the nucleus removal, I noticed that there is a small opening in the posterior capsule. It was pre-existing. So now I used HPMC here, and later on I realized I should have used viscoat for this case to plug the hole in the central area, going with bimanual irrigation aspiration, and some of the cortex is taken out. But here again, the mistake number 2 was irrigation was placed very close to where the PC dent was present. That should not have been done. I should have removed the cortex away from the posterior capsular rim, and after that access the area of capsular bag to remove the cortex at a later stage. And I should have used a visco shield strategy to plug the central hole so that the anterior vitreous face would not have got broken, and I would not have had the vitreous present. So anyway, limbal vitrectomy is performed. 1:2 dilation, triamcinolone acetonide staining. It's very important for us to visualize the vitreous. So after the vitrectomy was done, I thought I'll use the same cutter, the irrigation aspiration cutting mode. This is actually a dual linear control phaco machine. So that was going on, but somehow it was not happening very smoothly. So then I changed my strategy, and then I injected some OVD into the anterior chamber and went for a dry cortex aspiration. So the dry cortex aspiration does extremely well in these kind of situations where you do not want too much of turbulence in the anterior chamber. There's a large PC dent and you have already done a vitrectomy. And before I implant the lens, it is again imperative to ensure that there is no vitreous strand in the anterior chamber. And once that is done, the capsular bag is compressed in the periphery. I'm going to keep the lens in the ciliary sulcus. So it's a 3-piece hydrophobic acrylic lens. The leading haptic it just grazes on the anterior capsule and it goes behind the iris into the sulcus. The trailing haptic is not dialed, but I just compress it and keep it under the iris, and it goes into the sulcus. And subsequently, after the lens is properly centered, sulcus is not a very good place for long-term centration. So the lens optic has to be locked into place by obtaining an optic capture. So it is pushed to the rexis margin posteriorly, as you see here. So now the lens, though it is a 3-piece lens, 13 millimeter length and 6 millimeter optic, it is going to stay very stable in the ciliary sulcus. And this is the post-op picture. This patient has been under follow-up. He has done well. So friends, I would like to conclude by saying that all these patients need preoperative counseling. Even if you feel that there is no little chance of PC dent happening, but they should be counseled. And the surgical strategy has to be customized. You use appropriate phaco parameters and phaco strategy. Use a strategy to minimize damage. No cortical cleaving hydrodissection, hydro-free dissection. I don't do hydrodelineation because when you try to do hydrodelineation, there may be accidental cortical cleaving hydrodissection. Inside-out delineation was, I think, developed to prevent this complication. I don't do it, but many surgeons do it and are pretty happy with it. Maintain a deep and stable anterior chamber at all stages. Do a proper anterior vitrectomy and maintain a necessary IOL inventory. Because you may not be always, it may not always be possible for you to keep the lens in the bag. And a single-piece hydrophobic acrylic should not go in the sulcus, so you should have a 3-piece design available with you. And in case you don't have it, you can keep the patient aphakic and take up the patient for a secondary implantation at a later stage. So this is the strategy that I've been following, and I've been quite happy with managing my post-polar cataract with a PC dent almost 3% to 4%. And I don't think I create a posterior capsular opening if there is no pre-existing posterior capsular opening. And that is the strategy that I follow. Thank you very much for your kind attention.
Thank you. Thank you.